like to do is give you a brief interview of where we believe that the LHIN has been adding value over the last, since we last came together in 2011. You can see the 5 areas here: critical care, emergency department wait times, e-health, access to care and behavioral support services. So I'll give a brief description of each of those, and I'm certainly happy to answer any questions about those. And then the second part of the presentation is about our Integrated Health Service Plan. So our Integrated Health Service Plan is our 3-year document, our strategic plan that we're putting in place for the 3-year period starting in April of next year. So where have we added value with critical care? And I referenced Dr. Mike Sharp in my opening comments. Mike has been with us in the critical care lead position, I think since 2007. I've been here for quite a while, and has been a real advocate for ensuring that critical care units, intensive care units, are working not as individual units, but are actually working as a system. And Mike was instrumental working with our staff in implementing the Life and Limb policy, and I'm sure most of you are familiar with the Life and Limb policy. Life and limb is where that no patient whose life or limb is threatened can be refused treatment at a hospital. And I'm sure, again, in this audience, when I tell the story about that it used to happen, aren't shocked. But when you tell the public that in the past where a family physician from Listo or a family physician from Wingham is calling to get access to treatment at LHSC and are saying, no, we don't have a bed, the public can't understand that. But that's the way the system did function in the past. Mike, again, has been very instrumental in rolling it across our LHIN. Has been extremely successful, and so successful that what we've done in the Southwest LHIN is now being rolled out provincially. So the other 13 LHINs are now embarking on the Life and Limb policy. The Critical Care Secretariat is taking this as an initiative that they want to roll out, and the intent is that it will be rolled out provincially by December 2012. And in a way, it's a very good thing, because if we accept any patient, if life or limb is threatened, we were getting requests from outside of our LHIN because they knew that the hospitals here would actually accept those patients. So it's good that we're rolling it out provincially. Mike has also been extremely important in terms of the extramural physician. So again, this allows those physicians outside of, I guess in London as well, but outside of London, to have a consult with a critical care intensivist at LHSC 24 hours a day, 7 days a week, within 10 minutes. So that process happens through CriticCall. So often it's that physician who's in a small community has a question about, needs advice, needs a consult, and allowing that quick consult will ensure that if the patient doesn't have to travel to London, they can stay and be observed within their own home community. And I know Rob has given that example a lot of times when he speaks to different audiences. And finally, on the critical care front, long-term chronic vents, we have a number of patients that are on long-term ventilation. Many of these patients are sitting in an ICU. Many are sitting at the LHSC ICU. They don't need intensive care. They need supports, but that support can actually be provided within the community. It can be provided within a community hospital. And so again, we put a lot of effort into this together with Dr. Dave Lisa and Kathy Monson, who's an MP at LHSC, to ensure that these patients are getting the care that they need outside of an intensive care unit. And many of these are young men that are on chronic vents, and that's not where they want to live. They want to live at home. Participation House is one of our community organizations here that actually provides that service to those patients in the city of London. The second area is emergency department wait times. And again, it's taken us a while, but we've made great progress in getting our wait times down. This is something that the Ministry of Health measures all LHINs on. It's extremely important not only to the Ministry of Health, but to the Premier to ensure that the emergency department wait times are down. So you can see the admitted patient length of stay here back in Q1, which is of 11-12, so that'd be April 1st, 2011, was at 28.8 hours. We're now down to 16.8 hours in Q2 of this fiscal year. And if you look at our wait times for non-admitted patients, so those wait times for the top paragraph is high acuity patients, high acuity clients, the second one, low acuity clients. 90% of our non-admitted high acuity clients had a wait time of less than 6.6 hours, which is just a bit over our target of 6.3 hours, but is below the provincial target of 7 hours. And in the Southwest Lynn, we're consistently in the top 3 for the lowest wait times for those non-admitted high acuity patients. And on the non-admitted low acuity patients, so these are the CTAS 4s and 5s, had an emergency department wait time of 3.8 hours or less, below the provincial target of 4 hours. And again, we're ranked in the top 5 of the LHINs across the province. These wait times still aren't great. Nobody wants to wait in the emergency department longer than they have to, but we are performing better than other parts of the province, and it's because of the great work that's been initiated in our emergency departments and our partners with our hospitals, our physicians, and then our staff working closely with them. E-health. So this slide could actually be a presentation in itself. We've done a tremendous amount of great work and hearing very positive feedback about the work that we've been doing. And hopefully everyone in this audience, again, knows about Spire. Spire is the Southwest Physicians Office interface to regional electronic medical records. So that allows lab reports, diagnostic imaging reports, medical documents to be delivered electronically from the hospital to family physicians EMRs. So that the documents are actually downloaded right into the EMR. There's no scanning, there's no faxing anymore. We have 400 plus physician subscribers signed up within the Southwest Lynn. We're now rolling it out to the Erie St. Clair Lynn because of the success we've had. And as I said earlier, Glenn Lentang from our office, our CIO, and his team have been out the last 3 weeks prior to this, having similar physician engagement sessions talking specifically about Spire, and very positive feedback that we've got from the physicians about the success of this program. And again, talking around our table, Spire came because of feedback that we got from physicians. And I can remember it was Dr. Kathy Folds, who's a family physician here in our office, gave me a hard time. I called LHSC and gave Diane Beatty, who was the CIO at that time of LHSC, a hard time saying, you know, faxing this information back and forth between the hospital and family physician offices is just crazy. And we agreed. And from there, it started small, and we gradually rolled it out to across the Southwest Lynn, as I said, having over 400 plus physicians. In the second part of this, CSWO, CSWO is connecting Southwestern Ontario. The intent of this is that the 4 LHINs in Southern Ontario, we now call ourselves a cluster, so that's the Erie St. Clair LHIN, us, the Waterloo Wellington LHIN, the Hamilton Niagara Home and Brant LHIN, are working together to move towards the creation of an electronic health record. How we're doing that is with 2 foundational pieces. One is Spire, and so we've got Spire here in Erie St. Clair, it'll be rolled out to Waterloo Wellington, Hamilton Niagara Home and Brant. And then with Clinical Connect, which is a clinical viewer which is being used right now in the Hamilton Health Sciences Center with the Hamilton Niagara Home and Brant LHIN. So those 2 foundational components will help us get to the point where CSWO is put into place. CSWO is a project that's funded by eHealth Ontario over the next 3-year period. There's a significant amount of investment that will be coming from eHealth Ontario to assist us with this. And again, it's an electronic health record not just for primary care and hospital, but the overall intent is that the electronic health record would also be available for other partners within the system. It includes CCAC with the CRIS system, includes the community support service agencies that need access to that information. So lots to do on the eHealth front. We've had lots of success, and CSWO is really pushing us to the next level to ensure we continue on the success that we've had to date. Access to care. So this has been another key initiative for the Southwest Lynn, working in partnership with the CCAC, our community support service organizations. And it really has 3 prongs. So you can see the primary care, the community care, acute care, and post-acute care. Access to care is ensuring that we get the right place, right care, right time. We have consistent eligibility criteria, coordinated access through the CCAC, standard definition services and programming. What this all means is that on the primary and community care front, we went through a process to identify where we have adult day program capacity. So adult day programs are those that are offered at Dearness Home here in London, McCormick Home, allow those seniors with dementia to have a day away. It could be 3 or 4 days away. Gives their caregivers an opportunity for respite as well. We did an analysis of where there's a need for adult day program capacity across our LHIN. We identified that there's a need here in the southern part of the LHIN as well as in the northern part of the LHIN. Our board just approved an investment to ensure more capacity is being put into places like McCormick Home, as well as with Home Community Support Services in Grey Bruce. We've also looked at the assisted living criteria, looking at who's in assisted living facilities or homes right now, and there's some real variation, whether those clients need to be there, whether they can be supported in a different environment through supports through the CCAC. That assisted living approach that we've looked at has allowed us to ensure that we make effective use of that capacity. And the final thing on primary community care is standard fees and funding. We've done an analysis of what people have to pay for a bath, for a home visit across the Southwest Line. There's wide variation in terms of how much people would pay for a bath through a community support organization. We want to ensure that we've got consistent standard fees, and then associated funding that goes along with that. There's a lot of work that's going on, and that's just the first prong, and I'll go into the next two to move this along. In acute care, Home First is the key initiative that we're moving forward with the Access to Care banner. Home First is when that frail senior shows up at the hospital, that the conversation doesn't start off with, well, next step for that frail senior is long-term care. The conversation should be, how do we get that frail senior back home? And that conversation has to start with the nurse, the physician, all the interaction that frail senior may have within the hospital environment. And then coupled with that is ensuring that the CCAC has the capacity to take those frail seniors back home with some additional supports. So for an intensive period of time after they're discharged from hospital, ensuring that the frail senior can get 24/7 care at home for up to a 3-week period. You have to put some limits on it, because if you didn't do it for a 3-week period and you allowed 24/7 care forever, you'd eventually create financial problems for the CCAC. But through some additional funding from us, the CCAC has been a great partner in terms of getting those frail seniors home and getting them able to live independently and safely at home. And finally, on post-acute care, we've done an analysis across our LHIN of all the complex continuing care and rehabilitation beds. And we've made recommendations. You can see these recommendations on our website, where we've looked at where there's where the capacity, or where the number of complex continuing care beds meets the capacity that's required, or meets the needs that are required, I should say, and where there's some areas where they need more CCC beds, and some areas where they actually have too many CCC beds. And in general terms, you look at places like St. Thomas, Oxford County, they actually have more CCC beds than what would be dictated by what the population requires. And so what we're suggesting, and these recommendations will be going to our board starting in the next calendar year, January, February, March, around the realignment of those beds and that capacity. This has significant. It's easy as a system planner to sit here and say you need to do this, but if you start talking about moving beds out of a particular community, out of a particular hospital, particularly small hospitals, local communities get concerned, local councils get concerned. So as part of this whole process, we're meeting with local municipal councils to ensure they understand why we're doing it and the benefits to the system. And I've really described a good piece of all the 3 streams from the Access to Care on this slide here. And again, there's lots more information on our website. I'm just giving you a taste of what we've got with across the Southwest LHIN. And this is just some data looking at active ALC designated patients at London Health Sciences Centre. So if you go over to the left-hand side of the column, you can see at Victoria site, University Hospital site, and then in total, I'm looking at the top chart. The bottom row is the entire LHSC campus between Victoria and University Hospital. You look across and you can see back in July 2011 we had 103 ALC patients, those patients waiting for an alternate level or an alternate destination. And we're now in October 2012 looking at 80 patients. We've got a lot more work to do. I think one of the biggest areas of success is identifying those patients that alternate level of care, waiting, excuse me, waiting for long-term care. So in the bottom chart, you can see new ALC long-term care designations. Back in July 2011, there was 12. It was reduced down to 6 in March, 3 in June, and in September it was actually 0. So we're ensuring that people are getting the care that they need in an appropriate time. And finally, of successful initiatives that the LHINs have been adding value across our geography is behavioral support services. So this is ensuring that we're giving that support to people with responsive behaviors who live in their own homes or long-term care homes. We've created a number of interdisciplinary mobile teams to ensure that those patients, those residents in long-term care homes that have responsive behaviors, behavioral issues, can get additional supports beyond what's being provided within their own facility or at home. One other component to this is that we've funded the Southwest LHIN. 38 of our 78 long-term care homes now have access to OTN, the Ontario Telehealth Network. At our July board meeting, the board approved all of the making up the remaining long-term care homes to make sure that they have the equipment to connect into the Ontario Telehealth Network. So lots of good things going on within the Southwest LHIN. Again, these are just a couple of samples of work that we've done over the last year. So I'm going to switch streams a bit here, as opposed to talking about some of the issues that we've been working on, looking into the future. In the next few slides, talk about the development of our Integrated Health Service Plan. And if you haven't been aware of this, we've been doing a lot of communication, consultation. We've had community engagement sessions across the Southwest LHIN in many different communities over the month of September. And the draft Integrated Health Service Plan was presented to our board at its meeting in Fort Rowan last week. And the overall theme of the Integrated Health Service Plan is to ensure people can live safely and independently at home. So back in 2010, our board approved the blueprint. And the blueprint is our vision for the healthcare system up until 2022. So it was for a 12-year period. And if you can boil down what the blueprint was, it was ensuring that we have a unified system of care. So we don't have sectors anymore. We have people working across sectors, all striving toward the same goals and objectives within the healthcare system. That's the gray line along the bottom would be that time frame of 2010 to 2022. Within that, we also have the legislative requirement, and from an organizational requirement to create an integrated health service plan. Our first one was in 2006, which took us to, or 2007 to 2010. Our second was 2010 to 2013. And the one I'm going to talk to the group tonight about is from 2013 to 2016. And then again in 2016, we'll refresh and come back with new priorities. So, for our plan going forward, starting April 1st, 2013, we have 4 strategic directions. And I'll give you a quick overview of each of these to give you an idea of why they're important and why we put them into our Integrated Health Service Plan. And these directions have been vetted with a number of different provider groups, from our Quality Advisor Group to our Critical Care Group to our Health System Leadership Council, members of the public, members of different communities across our geography. So they are enhance access to family health care. And for those of you that are familiar with the Government's Action Plan on Healthcare that was released in January of this year, the minister indicated that their planning and accountability for primary care will be coming to LHINs. So obviously we want to make sure that that's one of our priorities moving into the next 3-year period. And I'm sure there'll be lots more discussion in our breakout session tonight with Dr. Annis. The second one is improving the coordination of healthcare delivery. Third is improved prevention and management of falls, wounds, and infections. And 4, increase the effectiveness and value of our health system for people. So what do all of those mean? A quick snapshot of each. So enhancing access to family health care. We want to ensure that people have timely access to family health care. If you look at the stats now, a good percentage of the population within the Southwest LHIN does have access to family health care. But the question is, can they access that in a timely fashion? Do they have to wait 3, 4, 5, 6, 7 days before they actually get an appointment with their physician? And Dr. Annis has been a real proponent and working closely with us in terms of looking at open advanced access, where those patients that are looking for an appointment can get it same day or next day with their family physician. So we have lots of work to do here, but we want to ensure that people can get that access to family health care, because if they're not getting the access to their primary care physician, it means that they're going to be showing up at the emerge in places that we don't want them to be seen. So that's a key point for us. And I should have said off the top, with primary care, in my eyes, primary care is the foundation of the healthcare system. I think sometimes we get a bit distorted in terms of where money is spent and where priorities seem to go, that hospitals are the foundation of the healthcare system. Primary care physicians are the foundation of the healthcare system. And we need to make sure that they're well integrated, connected with the rest of the system. So in the third bullet point, also ensuring that patients have increased access to local and Lynn-wide interdisciplinary teams and across healthcare settings. I don't think I have to tell anyone in this room that primary care physicians, or patients could be a have or have not, depending on whether they're part of a team environment or not. Is that fair to a patient that within a family health team they'd have access to a social worker, dietitian, other components of family health care, or is it a fee-for-service standalone physician wouldn't have that ability? We'd like to see everyone have access to those components. There's a lot of work to do. There's funding issues associated with that, but we need to make sure that we're moving in that direction. The second strategic direction for us is responding to the needs of the population of people with the greatest unmet healthcare needs. So you look at where a large percentage of the healthcare resources are spent. 1% of the population actually consumes 34% of healthcare resources. So why? We're just getting to that point of understanding why that 1% is consuming such a large resource. Obviously, you take out the people that maybe have intensive treatment, chemotherapy, cancer surgery that would be consuming a lot of resources in a short period of time, and look at those patients that are consuming a great deal of resources. Mental health obviously rises to the top of the agenda. So we need to look at who's in that group. How can we actually help them navigate the system better and get the supports that they need? And there's a lot of work going on, not only within the Southwest Lynn, but across the province to ensure that we are responding to that population that is that's consuming such a great deal of resources. The third strategic direction for us is in improved prevention and management of falls, wounds, and infections. So we need to look at safety and quality. We talk about safety, and I think in our draft IHSP, we've only talked about the safety component. I think quality needs to be brought into that mix as well. But ensuring that those frail seniors don't have a fall at their own house or fall within a long-term care home. Because you look at the percentages of patients frail seniors that have falls, and where they end up in terms of additional care required from the system, and ultimately their lifespan as their care is provided. We also need to look at wounds, ensuring we have a consistent approach to wound management across our land. We've done a great deal of work with our hospitals with the CCAC, and we intend to advance that work to ensure we've got a consistent practice around wounds. And adverse drug events and infections are obviously other areas where we need to ensure that patients are kept safe so they can continue to live independently and safely at home. And finally, increase the effectiveness and value of our health system. So over the last 6 years, we've made great progress within the Southwest Lynn, and I've identified some of those areas where we've added value over the last 6 years. We don't want to turn our back on those, so this last priority is ensuring that we continue to make progress on the initiatives that we've advanced. Excuse me, a great example of that is MRIs. Back 5 years ago, our MRI wait time was somewhere around 158, 160 days. We've now driven it down to, it was as low as 50 days, probably about 8 months ago now. It's starting to trend back up again. But we've made significant progress in terms of hospitals changing the way they, quality initiatives around MRI treatment, MRI service, to ensure that they're driving those wait times down. But we're also across the Lynn system, and it's an example that I give many times when I speak to the public. Back in 5 years ago, we had one MRI and one sound, and we had the MRIs here at St. Joseph's Hospital and LHSC. The wait time for the MRI at Owen Sound was 28 days. The wait time for the London hospitals was over 200 days. So we actually sent we had our diagnostic imaging task group came together. The agreement was made that we send a letter out to physicians here in the Perth area to say that you don't have to always refer down to the south, to London. You can actually refer them up to the north. So that's one strategy. We're looking at things across a larger system, allows us to address some of the pressures that we're facing across the entire system itself. So we've done lots of great work, and so this last priority is ensuring that we don't lose track of those, and we continue to focus on the successes that we've seen. So that's a quick overview of some of the areas where we think we've added value over the last year, a quick overview of our integrated health service plan, what our priorities are. Our integrated health service plan, as I said, went in draft form to our board last week in Port Rowan, and will be coming for final approval at its board meeting at the end of November in Owen Sound. The integrated health service plan will be, if it's approved by the board in November, will be rolled out and ready for implementation in April 1st, 2013. So with that, I'll stop and say that if you do have questions or comments or want to get more information about some of the things that I've spoken about, please go to our website. And again, happy to answer any questions that